Hello, our topic today will be the lambdoid synostosis, which is a rare occurrence, but can be found in many different multiple synostosis in children, and it has a typical presentation with a telltale deformation of the occiput, as shown on the right. And we shall focus especially on different surgical techniques which can be used according to each individual case. First, what is the function of the lambdoid suture? Anatomically, it is three-dimensional. That means it behaves like a shell with progressive growth from this suture, which allows a three-dimensional growth with conservation of the shape. So the growth pattern is curvilinear. It allows occipital growth and parietal anterior growth as well, because it is between the occipital and the parietal bone, and it allows a significant increase in intracranial volume. And you see here on the curve of the head circumference in children, it is striking how it is similar to the shape of this shell, and it is very interesting to think about how the nature is able to imitate mathematical laws. So what happens in lambdoid synostosis? As I said, the function of the suture is occipital posterior growth. So the consequence of the synostosis, here we have the normal skull and in superposition the bilambdoid synostosis, which shows the difference. So when the occipital posterior growth is impaired, we have occipital flattening, which can cause tonsillar herniation. Then we have parietal anterior growth, which, and in this case, in the case of synostosis, we have a retained coronal suture and a flattened forehead. It has a facial impact because the forehead is retained not just backward but upward, so the orbit is higher as well as the maxilla. But we also have a stimulated coronal suture, so we have a mechanism of compensation which leads to an enlargement of the frontal bone. We have also a stimulation of the sagittal suture, so we have compensatory mechanisms, but these mechanisms are limited, and when the compensation reaches its limit, we can have raised intracranial hypertension. This is a counterexample of a normal variant which is named batrocephaly, which when we have a redundant occipital suture, as you can see on the CT scan, we have a Mendozal suture which are joined in the midline. So it acts as a supplementary occipital suture, and you see the very typical pointed occiput, which has to be differentiated from scaphocephaly, because obviously the parietal region is well formed, so it's not a scaphocephaly, it is batrocephaly. So it shows it is the opposite, if you want, of lambdoid synostosis. So how do we take the surgical decision? The aims are morphological correction in many cases, cerebral decompression, especially when there is posterior crowding with tonsillar herniation, and especially in very young children. Then we have to discuss the timing, because the timing can be very early in emergency in newborns when they have breathing and eating difficulties or papilledema. But if it's possible to wait until 9 months, we are in better conditions to do a large cranioplasty, which is a big surgery with the risk of bleeding. So we have basically two different situations. So the technique will depend on the age, because we don't do the same surgery at birth and at 9 months, whether the synostosis is uni or bilateral, and if it is isolated or in the context of multilateral synostosis. First, we see the linear craniectomy, which is surgery we may need to do in small infants, even newborns, with a Cloverleaf syndrome with mostly posterior compression. So we have to do a linear craniectomy. We have to be very wary of the lacunae in the bone. So we have to carefully elevate the periosteum from the bone with regines, and then dissect the inner bony ridges, which can extend very deep into the cortical sulci. And we have to remove the bone without damaging the dura. And we have to be very careful of the remaining sutures, where the dura can be very adherent to the bone. And the craniectomy progresses by tango steps, as said by Patrick Delem, who was my mentor, using the rongeur, two steps ahead, one step behind, in order not to bite on the dura mater. The installation is in procubitus on a horseshoe headrest, so it may be difficult to find a horseshoe small enough to adapt the child, because the incision line, as you can see, is rather anterior, because we may need to expose the occiput as well as the parietal bone, and we have to anticipate that in the future that the baby may need another surgery for anterior decompression. The head is slightly elevated in order to diminish the venous pressure, and the occiput is exposed. I think it is a bit overambitious to try to expose the foramen magnum in small babies. In older children, it's possible, but at birth it may be dangerous because of the transosseous veins. The airways, of course, must be clear, so the anesthetist can do his job in good conditions, and we have to avoid, of course, ocular or venous compression. This is an example of a very small baby who had a prenatal diagnosis of cloverleaf syndrome with tonsillar herniation, and at birth he had severe eating and breathing difficulties. He had no fasciostenosis. He was severely microcranic and with a brachycephalic head. So he was very unwell, and we decided a surgery on the 9th day of life. We did a perioccipital and parietal craniectomy, as shown on the CT on the lower line, and he was markedly improved, and he had better cranial shape. And also we see on the MRI before and after surgery that the surgery was efficient on venous compression, because on the left we had compression of the transverse sinuses, which looked much better on the control MRI. So we see here operatively where the sinuses could be decompressed. Then we see the cranioplasty with overturned flaps. So this is a surgery we do mostly starting at 9 months. It can be done later. It can be unilateral if needed. So we have, in this case, we have to correct the posterior pole, but you see that the whole calvaria is deformed because of this synostosis. Which shows that the impact of the parietal bone can lead to facial dysmorphism. So in this case, we do corrective surgery, especially when there is a facial involvement, and of course, decompressive surgery. We do a quadrangular bone flap, which is turned 180 degrees, so that the suture, the patent suture, will be on the synostotic side. In addition, we do barrel staves so that the parietal calvaria can catch up on the shape of the occiput with the normal of the non-synostotic side. So it gives a good correction of the shape of the occiput, but also of the face, as you can see on the picture down. But we have to be very careful when there is a unilateral synostosis, because in more than half of cases of unilateral lambdoid synostosis, we have agenesis or atresia of the transverse sinus. That means that on the non-synostotic side, you have a hypertrophic transverse sinus, as shown here, number 2. That means also that during surgery, you can have difficulties in elevating the dura mater from the patent suture, and it can be very dangerous. And in this case, it was we were very close to catastrophe because there was some severe adherence of the dura of the overlying the transverse sinus adhering to the patent suture. When the synostosis is bilateral, it may be needed to do posterior calvarial expansion, like in this boy who had a Crohn's disease with a fasciostenosis but no closure of the coronal suture. He had a tonsillar herniation, so we decided to do a posterior cranioplasty for calvarial expansion. And this is the kind of bone flap we did with a decompression of the transverse sinus. The flap was lordosed and refixed on a tongue and groove construct. And this is the post-op CT scan, which shows a significant expansion of the calvaria. The child was markedly improved, but the result on the tonsillar herniation was modest, as shown on the MRI. And later on, he will have to undergo midfacial distraction. There is an alternative to this surgery, which is posterior distraction, like in this case, but this was a multistructural synostosis, so it was part of a plan. And as I said before, we have to have to do a versatile incision, so it can be used for either posterior or anterior approaches, because we have to anticipate further surgeries. In this case, we did a linear craniotomy with some barrel staves, and we put this structure which allowed a posterior expansion. So there is a question regarding lambdoid synostosis, which is what to do in case of tonsillar herniation. Is it enough to do calvarial expansion, or could we do just occipital decompression? Which both pros and cons of these two surgeries must be balanced. Calvarial expansion addresses mostly young children, especially cloverleaf, as I showed, but occipital decompression may be enough in older children, near adults, for which the cerebral growth is almost done, especially if the head circumference is preserved. Regarding the presenting symptoms, calvarial expansion is indicated in case of intracranial hypertension, or if there is a morphological concern, whereas occipital decompression is more indicated in case of symptoms of Chiari. And also if there is a severe tonsillar herniation, especially if there is a syrinx, because it is a more direct approach to syringomelia. However, decompression, calvarial expansion can also be efficient in some cases with syringomelia. So this is the experience in Yale over 16 years. We had 41 patients had lambdoid synostosis, but only a fraction of these had purely lambdoid synostosis. This accounts for about 6.3% of synostosis, and we noted that most of the cases were recent. That means we had probably an increased focus on this condition, and it shows also the influence of the laptop imaging processing, which allows the surgeon to study more in depth the lesion. We are more frequent cases in children, in males, which allows especially which accounts mostly for the Mercedes-Benz form, because in fact we found in Mercedes-Benz the male predominance we have in all sagittal synostosis. And also we find a high number of syndromic cases in Mercedes-Benz syndrome or oxycephaly. So surgery were craniectomy in 9 cases, cranioplasty in 26, and posterior fossa decompression in 15. And 14 of them had hydrocephaly, requiring shunting in 5 cases. So we note that a little more than 1 in 2 had only one surgery, but many children had 2 or more surgery, and some of them were not operated at all. So the result on the morphometry, we note that it depends on the anatomic conditions. If it is isolated lambdoid synostosis, we have the cephalic index is much closer to normal, while it is much lower in case of Mercedes-Benz, which looks much like scaphocephaly. And after surgery, there is a good correction in case of Mercedes-Benz syndrome. And regarding the head circumference as well. So in conclusion, we see that we have different possibilities for surgery according to the timing of surgery, the age of the patient, the presentation, whether the synostosis is uni or bilateral, whether the synostosis is purely lambdoid or multistructural, and we have to anticipate that the lambdoid synostosis is only the start of a long, complicated story. I anonymized this image because this patient is a celebrity. I thank you for your attention.